webinar on diabetes in pregnancy, and mainly be speaking about GDM as representing NCDs. And I would like to start first with introducing my Indian family that you see them on the right. And we kind of started our relations around about 9 years ago when we met in New York at the United Nations. And that was a meeting organized by WHO. And we are here pictured with Dr. Margaret Chan, the Director General of WHO, and with me, Anil Kapoor and Hema Divakar. And that was a very, very important meeting. That's why I use this slide very, very often, because that kind of was the first recognition of the mega organizations, the United Nations, WHO, that we are, and stating that we are facing a slow motion disaster. About that time, Margaret Chan published an editorial in the New England Journal of Medicine and clearly declared we are facing a slow motion disaster. And she delineated there is an increasing global crisis in NCDs. NCDs are associated with mortality, morbidity, and long-term disability. And 2 out of 3 deaths globally are attributed to NCDs. But the main take-home lesson that actually started at that time in September 2011, that NCDs are programmed and imprinted during pregnancy. And if you want to start and interrupt the vicious cycle of NCD programming and imprinting, you have to start during pregnancy. That's why diagnosis and management of all pregnancy complications, it's not only GDM, it's hypertension, hyperglycemia, obesity, any other pregnancy complication will produce at the end a future NCD. And I'll show you later in one slide how diabetes begets diabetes, or how pregnancy complication begets non-communicable disease. So yes, we have to diagnose and manage all pregnancy complications in utero. So that was the main lesson that was learned at that time. And since then, during the last 9 years, Hema, Anil, and myself, we are pushing this agenda as hard as we can, because pregnancy is a real window of opportunities. Have a look on the number of pregnancy complications. What do we mean in pregnancy complications and their maternal morbidity and fetal programming? We have globally every year about 135 million live births. Have a look on the complications on the right side. Maternal anemia, 55 million. Undernutrition, 26 million. Malaria, about 20 million. Obesity becoming a huge, huge burden on every community, not only in low-income countries, but in high-income countries as well, 42 million, and it's underestimated. As well as maternal hyperglycemia, it's really underestimated with only 21 million, but believe me, it's much, much more. Hypertensive disorder, about 10 million deliveries per year. And that's what I call the one slide presentation. And that's the main take-home message, because if you'll remember this slide, then you'll understand how diabetes begets diabetes, or how pregnancy complication begets an NCD, and how can we interrupt them. So how do we prevent NCD? How do we prevent the appearance of this Botero family and for 3 generations? So that's what we call in Figo, in our committee, the life cycle approach, as pregnancy as the window of opportunity. We have 3 entry points. The first entry point will be during the preconceptional management. There, when we get our lady who is not pregnant yet, we have to identify whether she had already an NCD, whether she has diabetes, she has obesity, hypertension, cardiovascular disease, mental disease. And if yes, we have to prepare her for pregnancy. She can't just get pregnant without without notice. We have to deal with it, and we have to prepare for pregnancy. Second entry point is the first trimester. The first trimester is becoming now a crucial, maybe much more important than the rest of the pregnancy, because here we can predict and prevent most of pregnancy complications. We can predict here GDM, preeclampsia, premature labor, IUGR, fetal growth retardation, even IUFD, fetal death, because if we identify them later during the second and third trimester, the disease is already here, the complication is already here. So all we have to do, we can only treat it, manage, and follow up, because the abnormal uterine environment and programming and imprinting are already in full action. So it's there. Then we end up with a safe delivery. But now the vicious cycle continues. It won't stop here. We obstetricians, many of you are diabetologists, and that's in your, actually, we are passing the game now, the ball, to your battlefield, to your playground. But it's together. It's a game that we have to play together, obstetricians and diabetologists together. Because have a look what happens in the postpartum. If we just follow here the offspring's health, it will go through neonatal insulin resistance, childhood obesity, early metabolic syndrome, PCOS. And I noticed that your next webinar is with Mark Molich on PCOS and other endocrine complication. And I was actually a fellow at Northwestern University when the room next to me was Mark Molich. And I won't tell you how many years it is before. It was in the late 80s, so quite a time. Then adulthood obesity, and then of course a full blown out NCD. For the mother, it's straightforward, maternal health, and we already have enough data. In a year, in up to 5 years, 50 to 80% of GDM mothers will have a full blown up diabetes, type 2 diabetes. Obesity. A hypertensive mother will have hypertension or chronic or cardiac vascular disease, mental disease. So this is the vicious cycle. How do we interrupt it? How do we cut it? It has to be an intervention in one of these three action sites. For me, the most important one will be now at the first trimester. And we are looking for more and more new technologies to come up with new ideas to predict pregnancy complication. Because if we will prevent a pregnancy complication, then we will prevent programming and imprinting for these two offspring. And then we will prevent, of course, the mother from continue with her future NCD. So this is our endpoint. So these are the three entry points, as you see, 1, 2, and 3. And this is new. This is the concept that we established during the last, I would say, 3-4 years, together with Emma, Anil, and our pregnancy and NCD committee. Now, we are living in the very, very fortunate and exciting era. I called it the modern FMFM era, because before we almost didn't have anything. We have prenatal diagnostic tests, biochemistry, ultrasound only emerged, fetal heart rate monitoring. But have a look what we have now. Biochemistry is still there. Have a look on NIPT, what we call now cell-free DNA. We can look for the fetal DNA in maternal blood. And again, it was only developed about 5 years ago. It's already old now because we have more and more data now on bioinformatics, big data, and artificial intelligence. We have more and more whole genome sequencing, microbiome, metabolomics, small RNA, and proteomics. So it gives us a huge hand in predicting and then following with preventing pregnancy complications. We also are very fortunate to have the outcome of 3 mega studies. We didn't have it before. The first one was the HAPO study, GDM, 25,000 pregnancies that were followed up during the HAPO study, and we have robust data, big data, that we can come up now with conclusions about GDM, how to diagnose GDM. Then we have the ASPRE study, 27,000 subjects that can predict hypertension in pregnancy, preeclampsia, and we can even have the proof for prevention of preeclampsia. 80 to 90% of preeclampsia now can be prevented by administering aspirin before the 14th week of pregnancy. And lately, we have the HAPO follow-up study with about 10,000 cohort from the previous HAPO study, follow-up of about 10 years, and we have clear evidence what happens to the mother and the offspring after 10 years. Why Figo? I'll go through it very, very quickly. Figo is the mega organizations that brings together professional societies of OB/GYN, like for you diabetologists is IDF. This is our IDF, International Diabetes Federation. This is Figo in the International Federation of Gynecology and Obstetrics. Have a look on the discrepancy between the right side here and the left side here. On the right side, and in the center, we have our 135 million live births per year. On the right side, we have low and middle income countries. Have a look on the numbers here. India, of course, in the lead. There is no other country in the world that have a production of 30 to 40 million deliveries per year. India is unique, a mega country in deliveries and, of course, complication of pregnancy. But have a look on the rest of them, Afghanistan, Pakistan, Bangalore, and the rest of it. Altogether, coming up to 55 million deliveries. Africa, 30 million deliveries. China, 18. Brazil and Mexico, 15 million deliveries. So almost all deliveries globally are on the right side in the low and middle income countries, as well as the complications. So all the complications are, of course, here. Have a look what happens on the left side. USA, America, the big America, 5 million deliveries. Europe, 5 million deliveries. So these two huge continents have about 10 million deliveries. The rest of it, 125, are here. But have a look on the discrepancy. All the guidelines for the whole world are being produced here on the left side by these two continents. So can they be adapted as they are to the right side, to low and middle income countries? And the answer is, of course, no. And that's why Figo enters the game and brings together all of us together, and we can change this game. We can adapt the guidelines that were started here, but to adapt them to the right side here, because we have the power to know and to have the unmet needs, to represent the unmet needs of the low-income countries, the low and the middle-income countries. So that's why the Figo Pregnancy and NCD Committee was established. It came to light in 2018 when we merged the Hyperglycemia in Pregnancy Working Group and Nutrition Working Group. Emma, Anil, and myself, we were leading the Hyperglycemia in Pregnancy Working Group for 3 years before, and Mark Hanson was leading the working group on nutrition. So we merged these two committees in order to come up with recommendations that will finally bring to an end the dispute about the management, diagnosis and management of GDM, with these 3 entry points highlighted. Like I said before, pre-pregnancy, pregnancy, and postpartum. This is the NCD committee, and fortunately, this picture was taken exactly 1 year before COVID-19 hit us, the pandemic. It was during the pregnancy deep Congress in Florence. It was even less than 1 year ago. And I'm very fortunate to have here with me Anil, Hema, myself, and the rest of the group. Many faces you'll recognize here. Those are the leading, I would say, global authorities on pregnancy and pregnancy complications. Have a look what we produced during our lifetime for this pregnancy and NCD committee. We produced the hyperglycemia in pregnancy guideline, Anil, Hema, and myself, HAP1 and HAP2. That's hypertension in pregnancy, Leona Poon. Leona already presented the HAP1 guidelines here in India, and we are coming very soon with HAP2, diagnosis and management. So hyperglycemia in pregnancy will be done. We came out with postpartum guidelines, which are extremely important to us in order to predict and prevent later type 2 diabetes. Came out last year. We are coming out now with the nutrition guidelines. We call it PONI, Pregnancy, Obesity, and Nutrition Initiative, led by Mark Hanson and Fionnuala McAuliffe. We'll be coming very soon with fetal growth guidelines, led by Nir Malamed from Toronto, Canada, and Ahmed Bashat from Baltimore, USA. And I'm very, very hopeful that we'll be able to bring the health economics initiative to a happy end. And Anil Kapoor is the leader of this group, and I'm not familiar with another person who has such a vast knowledge about health economics and their use in pregnancy complications. So hopefully we'll be there. The Figo Gdm Initiative started in January 2015. It ended up in October 15 with the publication of the International Figo Guidelines on GDM Management. It was published here. You can get it from our website. We produced infographics translated into every possible language that we can. And the main take-home message for you as well, that we recommend universal testing and the one-step procedure. It still has to be, I would say, absorbed mainly in the United States. So in January 19, 1.5 years ago, we came up with an editorial, Anil, David McIntyre, and myself, in the American Journal of Obstetrics and Gynecology, the main US journal, and of course, where we brought the evidence and support of the IADPHG criteria, the Figo criteria. At the beginning, most of the SMFM, ACOG group were with us on this paper. But for political reasons, and I don't want to start it again, they kind of decided to back off. Then Vincenzo Berghella still resisted, and he came with the one-step approach diagnosis a few days afterwards in the American Journal as well. So we ended up this dispute in November 18, when we had our global declaration in Rio de Janeiro, the postgraduate course when we had the SMFM Congress in Las Vegas last year as well, and the consensus commentary in AJOG. And lately, we came up with an editorial that was led by Anil towards a global consensus of GDM. We finally see a light at the end of the tunnel. That's what we think. Hopefully, our peers from America will join us because the evidence is here. And this is the roadmap. And I actually declared here, I don't want to hear any more debate about diagnosis and management because Figo is representing all of us. So we had a very, very low roadmap with this HIP declaration, the hyperglycemia declaration, that actually started in India, in Sri Lanka, with the SciDip Colombo declaration. And then we went to every possible continent and we signed the agreement there. And actually then we finalized in Bangalore, in India, in May 2018, and the final declaration, of course, in Rio de Janeiro, October 2018. So I don't want to discuss any more diagnosis. It's done for me. We came out with the postpartum, and that's I'm mentioning because it's very, very important. Because if you diagnose GDM, you actually diagnose, you predict type 2 diabetes. So why are we looking for markers that are going to cost us huge amount of money post-pregnancy when you ladies, 50% of the population that had a pregnancy and had a GDM the pregnancy is a physiologic marker. So if you had GDM, this is it. You don't need any other test. You don't need any other prediction. Just do it. Enter any program. And I'm sure that you have in India many, many programs how to deal with post-GDM. And it will be there. We started the Pregnancy and Obesity Nutrition Initiative led by Mark Hanson, Fionnuala McAuliffe, and I joined with Ronald Ma and myself. Those are the guidelines on nutrition that came up in October 15, 5 years ago. Think nutrition first, but this is the next one. This is the next step. Will be coming up either in September or in October with the next Figo obesity guideline that we call PONI, Prevention of NCDs in the Preconception, a Figo position paper, and it will be out. Now, as we are going to deal later with few management tools, I couldn't give the whole lecture on GDM, so I picked something very, very new. And this is attributed to Kavita Kapoor. Kavita is a leading person in nutrition and in pregnancy nutrition and GDM nutrition. And that's a paper that Kavita, Anil, and myself are coming out. It will be published probably either in September, October in the Annals Nutrition and Metabolism. And we call it Nutrition Management of GDM. It's a landmark paper. And I recommend everybody in the business, in the GDM business, to get it. And as soon as we'll have it in PDF, I'm quite sure that we'll be able to share it with you. So I just want to go with you through few very, very mild guidelines that were there. Globally, most widely used guideline for gestational weight gain is the Institute of Medicine, IOM. And Dr. Sriram outlined few questions later that deals with IOM. And it's here. The IOM guideline does not provide any specific recommendation for GDM. The Figo guideline states that normal weight and underweight women, the IOM guideline apply, and the rest of it. I don't want to go through all of it. We'll discuss it when we'll get to the questions that were produced by Dr. Sriram. There is the recommendation and weight gain. We'll deal with it as well later. Those are the Figo guidelines. That's the only table that I took from our guidelines that deals with pregnancy, obesity, and nutrition initiative that have about 10 key points to be addressed there during the preconceptional consultation. And they are extremely important. I'll share it with Dr. Sriram, and I'm quite sure that she'll be able to share it with you. The PONI declaration, I mentioned it here, was actually launched here. At the beginning of the year, Mark Hanson and Hema Divakar actually launched it here in India during the Artist Here presentation, and I'm sure that Hema will mention it a bit later. Very, very briefly to mention the pharmacological management, again, taken from the guidelines because Dr. Sriram addressed it later in her questions. Pharmacological management, if lifestyle modification alone fails to achieve glucose control, metformin, glyburide, or insulin should be considered as safe and effective treatment of GDM. Here is the recommendation for glucose monitoring in women with GDM. Again, I'll share it with you. Pharmacological treatment, insulin, glyburide, and metformin, all oral hypoglycemic agents are safe. Lately, and you asked me specifically, we'll address it later about the MIG study and the other metformin studies. Metformin is kind of preferred now to glyburide. My personal experience, and I'll be extremely happy to have you share your experience with me, it won't work on my patients. So I usually start metformin because I recommended it, but then I'll go back to glyburide. Glyburide is more effective, but I would be very, very glad to have you Indian experts to give me your input on it. Insulin treatment, we provided data that insulin analogs are safe and very, very efficient in pregnancy. And there is enough data, and the strength of our core recommendations is very, very strong. I'll kind of finish with inviting you all to join us, and hopefully it will take place. I really pray that it will take place because I want to see my friends, all my friends from India, all my friends from all over the world, because I haven't seen him for the last 7 months. And it's very rare for me not to meet my friends all over. So hopefully in April 21, we'll meet, all of us will meet in Saloniki, Greece. And I'll finish with what I call breaking news. That's something that I share with you for the first time. Hema and Anil don't know about it as well yet. So I'll be very glad to have their input about it. And that's coming from COVID. COVID pandemic forced us to make a change. Many of our patients refused to come to the clinics, to the hospitals, to meet their caregivers. So we are now trying to come out with a solution to move our office to home. So I called it New Approach to Pregnancy Management from Office to Home. And as you already know what I'm preaching for the first trimester and the second trimester and the third one. So let's have a look. We want to end up in safe delivery. So we are starting here a project in Israel. I'm working with a new initiative. We called it SABAR, Preg Care. We need an EMR, a very basic EMR, electronic medical records that actually will capture everything inside. And we can work with any care provider, HMO, hospital, community, private obstetrician, private patient, with whoever you want. Then first trimester, we'll have a call center here, and we'll try to get as many as possible tests that can be done outside. So early pregnancy or first trimester, we'll want a DNA panel for both parents. Then of course, for the mother, cell-free DNA, laboratory, NCD triage to see whether she already has an NCD. So then she's considered a high-risk pregnancy and maybe start with her new procedures. NIPT at about 10 weeks. And then outsourcing that we can't do it at home, of course. Nuchal translucency at 11 weeks. Chorionic villi sapling 11 and 13 weeks if she'll need it. Anomaly screening at about 13 to 15 weeks. And amniocentesis if she'll need it. So that's the first trimester. During the second and third trimester, we want mainly to kick off our protocol initiative with a home NST, fetal heart rate monitoring at contractions. That will be the kickoff. And we already have many, many tools that we can deal with it. So we can do NST, we can do fetal ultrasound, we can do continuous glucose monitoring non-invasively, and I show you very briefly about it, vital sign and laboratory, of course. Then it will, of course, follow with sonography, vital sign, glucose, continuous monitoring or diagnosis, and outsourcing, OGTT, anomaly screen, and fetal growth. And here are the tools that we already have in our hands. So that we already have. So all these are already available. All of them are available. That's the first trimester. But in the second trimester, we have many startups now that coming with more and more solutions that can be used at home. So the fetal monitoring system are all of them here. I'll be working with one of them, probably a company called Heramed that this is the device. This is the whole fetal monitor. It sits here. You give it to your patient, and she can monitor her fetal heart rate and contractions. It comes out from this box, and that's the device. This is the whole device. Then, of course, there is a new sonography tool that can be connected to your smartphone, and you can do very basic sonography on your patient. And hopefully, in the future, we can do much more. We can maybe even measure cervical length, but I'm sure that we'll be able to measure amniotic fluid index. We'll be able to use it for fetal movements. With vital signs, they're already here. These tools cost few bucks, very, very cheap. This is a new one, an innovation that Hema and Anil will be part of it. This is a continuous glucose monitoring tool, non-invasive. It's kind of a Fitbit. It's a watch that sits on your wrist, and continuously reads your glucose values. We are starting in September a huge study on prediction of GDM. We'll give it to about 300 patients, pregnant ladies at the 10th week of pregnancy. They'll wear it until 24 to 28 weeks of pregnancy. Then we'll do an OGTT, and then we'll divide the groups to GDM positive, GDM negative. And then we'll have huge data, big data, starting from 10 weeks. Hopefully, we'll be able to construct an algorithm that will predict GDM. This is a colposcopy tool, again, later, not to be used now, but at a later stage. Home blood pressure, we already have it, and there is a new tool for home OGTT. So this is the future, and of course, the outsourcing. I'll be very glad to discuss it with my friends in India, and if it will be of interest, then we'll bring the system to India as well. Thank you very much.
Thank you so much, Professor Hod. I think you have already answered a lot of questions that, and particularly, I think, stressed the importance of that pregnancy is a window to future chronic disease. And it's actually like a pregnancy